Complications of neuroaxial blocks. The complications of neuroaxial blocks are backache, nausea and vomiting, high or total spinal, subdural injection, spinal shock and cardiac arrest, maternal fever, systemic toxicity, and neurological complications. The neurological complications of neuroaxial blocks are headache, urinary retention, paralysis of the sixth cranial nerve as the commonest, transient neurological symptoms or syndrome, Cauda equina syndrome and other neurological deficits, meningitis and arachnoiditis, epidural abscess, epidural hematoma, anterior spinal artery syndrome. Backache is a famous complication of spinal anesthesia. Usually it is benign due to tissue trauma and requires more than symptomatic treatment. Rarely, it is an important clinical sign of epidural abscess. Nausea and vomiting may result from hypotension with subsequent ischemia of the vomiting center in the brain. Other theories to explain the occurrence of nausea and vomiting during spinal anesthesia: the increase of peristalsis due to sympathetic blockade with subsequent parasympathetic predominance. Third, the relaxed sphincters result in regurg of the bile into the stomach, giving such sensation. Finally, co-administered drugs, namely antibiotics and opioids. Total spinal blockade due to excessive cephalad spread of local anesthetic. It may follow either single shot spinal anesthesia or inadvertent intrathecal spread of epidural medication after an intentional dural puncture or catheter migration. Subdural spread of local anesthetic can also cause a high block characterized by high sensory level, sacral sparing, and incomplete or absent motor block. Single shot spinal anesthesia after a failed spinal or patch epidural may also precipitate total spinal blockade. Now, what are the possible mechanisms for high spinal blocks when a spinal block is attempted after a failed epidural block? It is either due to expansion of the epidural space, which may compress the spinal canal and encourage cephalad spread of intrathecal drugs. Also, rapid transfer of local anesthetic from the epidural space may occur across the dural hole. And finally, sufficient local anesthetic may be present in the nerve roots to decrease the dose requirement of subsequent spinal anesthesia. The clinical picture of total spinal apnea, which is transient, maybe coma, severe hypotension resulting from spinal anesthesia ascending into the cervical levels. Interestingly, apnea may occur without total spinal, with low sensory levels, and the cause here is sudden acute ischemia of the respiratory center from severe sudden hypotension. Treatment is supportive and may require intubation, ventilation, and support of the circulation by vasopressors and fluids. Subdural injection of local anesthetic is a rare occurrence, and it's to be noted, unlike the epidural space, the subdural space, what's called dural arachnoid, extends intracranially. The clinical picture is similar to total spinal blockade, but may be delayed 15 to 30 minutes, and the effect lasts 1 to several hours. Treatment is supportive as in the total spinal anesthesia. We require intubation, ventilation, and support of the circulation. The spinal shock and cardiac arrest. Here, vagal response due to decreased preload. It is preceded by bradycardia in young healthy adults. Prophylactic volume expansion is recommended with early atropine, followed by ephedrine and even epinephrine as indicated. Post-dural puncture headache is a common complication of spinal anesthesia. It follows dural puncture, whatever the purpose is, either it's intended for spinal anesthesia or for diagnostic purposes or for the injection of chemotherapy, for example. Sometimes the dural is scratched by the epidural needles without apparent CSF loss. This type of headache begins in the first 48 hours after spinal anesthesia, and it may last for days up to 2 weeks. It has characteristic features we shall mention soon. The theory of its causation is a decrease of intracranial pressure due to loss of CSF with subsequent traction on the meninges and brain sensitive structures. The predisposing factors are the needle itself, small with large size needles or wide gauge needles, and more with the needles with cutting end, called quink type needles, rather than those with small gauge and with pencil point needles. Small in the young, the female, the pregnant, more with multiple punctures. Interestingly, it is less in the obese. It has this type of headache has several characteristic features, being severe, frontal occipital, it radiates to the neck and shoulders. It's associated with neck stiffness, photophobia, and tinnitus. Interestingly or characteristically, it's worse when sitting, coughing or straining, and relieved by lying down. Rarely cranial nerve pulses encountered, even subdural and intracerebral hemorrhage, particularly if left untreated. The cause of decreased post-dural puncture headache in the elderly are decreased loss of CSF due to decreased elasticity of cranial tissue, decreased pain sensitivity in the elderly, and finally, decreased insensibility of pain-sensitive structures in the cranium. This type of headache should be differentiated from meningitis, subarachnoid hemorrhage, subdural hematoma, cerebral venous thrombosis, mass lesion, preeclampsia, sinusitis, and caffeine withdrawal. The treatment of post-dural puncture headache: recumbency, simple analgesics, adequate hydration, and stool softener to prevent straining. Caffeine and aminophylline, epidural blood patch, vasopressin, sumatriptan, which is a serotonin antagonist, is a serotonin agonist, and adrenocorticotropic hormone. The caffeine, 500 mg once or twice daily, given orally or parenterally. Caffeine is effective on prophylactic basis. The mechanism of its beneficial effects is related to cerebral vasoconstriction by blocking adenosine receptors. It also increases CSF production by stimulating sodium-potassium pump. It's not without side effects, and these are encountered when the dose exceeds 300 mg per day. And these are insomnia, nervousness, restlessness, nausea and vomiting, tachycardia, dysrhythmias, tachypneas, seizures, and in breastfed infants, they will suffer from sleep disturbances, irritability, and increased bowel activity. The use of epidural blood patch in the treatment of post-dural puncture headache. It should be attempted 1 to 2 days of the onset of resistant headache, sometimes in the presence of cranial nerve involvement. The use of epidural blood patch as a prophylactic is controversial. It has a great success rate, which is immediate. It exceeds 70%, may reach 90% in some cases, and it can be repeated. Radiology has shown that blood travel 1 space below and 4 spaces above the injection site. The effectiveness of the epidural blood patch in the post-dural puncture headache is related to obstructing the dural tear. However, CSF production is not so rapid, so other theories are involved, including increased CSF pressure by producing a squeezing effect, and finally, it may have cerebral vasoconstricting effect. The blood volume in the epidural blood patch is 15 to 25 milli autologous blood transfusion. The following are the complications of epidural blood patch. Pain, which is temporary. Backache is the commonest complication, and it decreases by stopping injection once pain is sensed, although this will decrease the effectiveness of the epidural blood patch. Other complications, though rare, are infection, bleeding, even in case of cerebral hemorrhage have been reported, nerve damage, failure of pain relief. Expression is called wet tap. What's wet tap? Wet tap is the accidental dural puncture during attempted epidural anesthesia or analgesia. The following protocol should be followed to decrease the incidence of post-dural puncture headache in case of wet tap. Injection of the CSF from the epidural syringe back into the subarachnoid space through the epidural needle. An insertion of epidural catheter into the subarachnoid space to be used for anesthesia or continuous intrathecal labor analgesia depending on the purpose of the epidural technique. And the catheter, the intrathecal catheter, should be left there in situ for total of 12 to 20 hours, and before its removal, injection of preservative 3 normal salines through this catheter. Other complication of a neurological complication of central neuroaxial blockade are urinary retention, due to involvement of the sacral roots, sacral 2 to 4 roots, and this will decrease the bladder tone and produce urinary retention. Very rarely, persistent dysfunction of the bladder occurs, and this means serial neural injury. The commonest cranial nerves affected is the 6 cranial nerves. Paralysis of the 6 cranial nerves during central neuroaxial blockade. It's to be noted that all the cranial nerves, except the first and the 10th cranial nerve, may be involved during spinal anesthesia. The 6th cranial nerve paralysis will be associated with diplopia and headache, in addition to squint. The onset is usually the 5th to 11th post-op day, may be delayed for 3 weeks. The 6th cranial nerve is long and tortuous, that's why it's most commonly involved. So the first theory is mechanical involvement of the nerve, mechanical compression of the nerve. Other theories are inflammation or toxicity by the injected drugs. To differentiate, diplopia may also occur following general anesthesia and after the use of muscle relaxants. Transient neurologic symptom or syndrome. And this is associated with pain in the buttock and legs or abnormal sensation, but characteristically without motor or sensory deficit. The onset is on the first day, persists for days, sometimes weeks, sometimes or rarely it may reach up to 1 month. Hyperbaric lidocaine is the commonest local anesthetic incriminated in this complication, and it's more commonly encountered in the lithotomy position and sometimes may occur following epidural anesthesia. It's explained by mild neurotoxicity or myofascial pain related to the lithotomy position. Treatment is symptomatic. Cauda equina syndrome and other neurological deficits. Peripheral neuropathies may occur. Usually mild trauma with the needle, and these are momentary and temporary and resolve. Sometimes, very rare, we got persistent neurological deficits, and these are due to inflammation and even demyelination in the nerve tissue by catheters or neurotoxicity by local anesthetics. Of course, trauma, and in particular injection in the spinal cord, induces cavitation, induces paraplegia, and this is related to anatomical variations between subjects and wrong counting of the space during lateral position in pregnant patients. Damage to conus medullaris will produce isolated sacral dysfunction. Finally, we have what's called Cauda equina syndrome. Cauda equina syndrome, the chronic adhesive arachnoiditis. It's presented by bowel and bladder dysfunction with evidence of multiple nerve root injury over days to weeks. The microcatheters used for subarachnoid injection were incriminated in the subject, and they have been withdrawn from the market. However, it may follow single-shot spinal anesthesia and also with epidural anesthesia. The anterior spinal artery syndrome, here it causes spasm or compression of the artery, producing acute ischemia of the anterior 2/3 of the lower spinal cord. This will lead to paralysis, which is often asymmetric, with loss of pain and temperature and preservation of touch and position sense. Trauma, severe hypotension, vasoconstriction are the causes. Meningitis and arachnoiditis may be septic due to inadequate sterilization, or aseptic caused by detergent, phenol, and powder. The epidural abscess will follow 4 stages over days. First is Backache. The second stage is radicular pain. Third is motor and or sensory deficits or sphincter dysfunction. And finally, paraplegia. MR and CT are required for diagnosis. Treatment of the removal of the catheter and catheter sensitive to select the proper antibiotics. Peritoneous drainage with fluoroscopy or CT guide, and may require surgical correction by laminectomy. To prevent epidural abscess, minimize catheter manipulation and use closed system. Use of micropore bacterial filter. The catheter should be removed or changed after 96 hours. Epidural hematoma. It occurs if spinal anesthesia is attempted in patients with coagulopathy or bleeding disorders. Insertion and removal of epidural catheter is risky and has the same effect as needle insertion. The onset is acute. MRI, CT, or myelogram are required for the differential diagnosis. To prevent such a complication, central neuraxial blockade contraindicated in patients with coagulopathy, those with thrombocytopenia, those with platelet dysfunction, and of course thrombolytic therapy. These are general guidelines to increase the safety of central neuraxial blockade. Use low-dose techniques and use additives as fentanyl allow this dose to work very efficiently. Try selective blockade if possible. Use the lowest possible space, and this will avoid spinal cord trauma and meanwhile will avoid unnecessary high spinal blockades. Seek out coagulopathy to avoid the complication of epidural hematoma. Severe pain or paresthesia down the leg during attempted central neuraxial blockade, you have to withdraw the needle and redirect. Use small gauge pencil point needles will reduce the occurrence of post-dural puncture headache. You must be always on the top of blood pressure, and so don't induce hypotension, particularly in a difficult position as disc position, for example, and maintain adequate venous return by avoiding dehydration. Give sufficient fluids, use of ephedrine, phenylephrine, atropine, and even epinephrine as needed. Neuraxial blocks in the setting of anticoagulant and antiplatelet agents. General principles. Use opioid or dilute local anesthetics or analgesia to facilitate monitoring. Be cautious in removal of epidural catheter and subsequent doses of anticoagulants. I mean, you have to follow the following guidelines. Routine neurological sensory and motor monitoring to detect hematoma, and then be extended for 24 hours in certain cases. These are the anticoagulant and the antiplatelet drugs we talk about: Warfarin, antiplatelet drugs, fibrinolytics or thrombolytics, standard or called unfractionated heparin, and finally low molecular weight heparin. Warfarin. For patients on long-term therapy, you have to stop warfarin and check prothrombin time and INR. For those on the perioperative thromboembolic prophylaxis, If the drug was given after 24 hours or more than one dose, we have to check for thrombin time and INR. But if also only one dose is given within 24 hours, we can proceed safely with the central neuraxial blockade without any tests. For antiplatelet drugs, aspirin is safe, but the newer drugs should be avoided. You have to stop these drugs for 2 weeks at least before attempted central neuraxial blockade. Thrombolytics, of course, are contraindicated for spinal anesthesia. As regards the standard heparin, called unfractionated heparin, for those on many dose subcutaneous prophylaxis, I mean 5,000 units twice daily, it is safe to proceed with central neuraxial blockade. For those intraoperative intravenous prophylaxis, the block should be deferred for 1 hour after the last dose. Removal of the dural caster should be attempted 1 hour prior to 4 hours after heparin dosing. For those on therapeutic doses and have partial thromboplastin time elevated, you have to avoid the block. If the catheter is in place, delay its removal 2 to 4 hours after evaluation of the coagulation status. For low molecular weight heparin, namely Kixan and others, it's not recommended to monitor anti-factor 10 level, and factor 10 level not correlate with the risk of bleeding. The procedure should be performed 12 hours after the last dose for prophylactic doses and delayed 24 hours for high or therapeutic doses. Single shot spinal is the safest. If not blood during central neuraxial blockade, delay low molecular weight heparin for 24 hours. For removing the catheter should be attempted 12 hours for small doses, 24 hours after therapeutic doses, and subsequent doses are given after 2 hours from catheter removal. Now some questions called exams. The non-neurological complications of neuraxial blocks are hypotension, total spinal cardiac arrest, backache, nausea and vomiting. The commonest neurological complication of neuraxial block is post-dural puncture headache. Mention 2 common causes of nausea and vomiting during neuraxial blocks. Number 1, hypotension. Number 2, co-administered drugs, namely antibiotics and opioids. Apnea during neuraxial blockade is due to either total spinal anesthesia. Number 2, acute sudden hypotension, acute sudden severe hypotension producing apnea of the respiratory center in the brain. To decrease the incidence of post-dural puncture headache, the needle should have the following characters. Number 1, small gauge. Number 2, pencil point. The main character of post-dural puncture headache, it is relieved by lying down and exaggerated by standing up and by coughing and straining. The following symptoms usually accompany post-dural puncture headache. These are neck stiffness. Number 2, photophobia. The beneficial effects of caffeine in the treatment of post-dural puncture headache. Number 1, cerebral vasoconstriction. Number 2, increased CSF production. The cranial nerve commonly affected during neuraxial block is the sixth cranial nerve. Why? Because it is long and tortuous. The lab test required before performing neuraxial block during warfarin therapy is prothrombin time, IN and INR. But there is no lab test required with low molecular weight heparin therapy. For patients receiving 4 units low molecular weight heparin spinal block can be performed safely after 12 hours, while those receiving high doses of the block can be performed safely after 24 hours. Removal of the epidural catheter can be done safely after 12 to 24 hours of low molecular weight heparin, depending on the dose of such heparin, and subsequent doses can be given 2 hours after catheter removal. Enumerate 5 neurological complications of neuraxial blocks. These are post-dural puncture headache, urinary retention, central Cauda equina syndrome, transient neurological symptom syndrome, anterior spinal syndrome, epidural abscess, epidural hematoma, among others. All cranial nerves can be affected during spinal block except the first and the 10th cranial nerve. The main character of transient neurological symptom or syndrome is the absence of motor or sensory deficit.